So welcome everybody to the third year of the Mindset Lecture Series sponsored by the Center for Psychedelics, Psychotherapy, and Trauma Research at the Icahn School of Medicine at Mount Sinai and the James J. Peters Bronx VA. And today it is a great pleasure to introduce to you our speaker, who is Dr. Michael Bogenschutz, who's a board-certified addiction psychiatrist, but also director of the New York University Center for Psychedelic Medicine. Dr. Bogenschutz's research began in 2011. He was one of the earlier people doing this work in psychedelic assisted psychotherapy. And this led to the first contemporary pilot study of psilocybin-assisted therapy for alcohol use in 2015. Dr. Bogenschutz was the lead investigator of a large multi-site randomized controlled trial of psilocybin for alcohol use disorder. And he has a recently published JAMA paper in JAMA Psychiatry. Additionally, he's the NYU site PI for both phase 2 and phase 3 trials of MDMA-assisted psychotherapy for PTSD and is conducting other NIH-sponsored studies for alcohol use disorder. So it gives me great pleasure again to yield the floor to you, Dr. Bogenschutz.
Okay, thanks so much, Dr. Yehuda, for that nice introduction and for the invitation to be here. I'm going to jump right in to present quite a bit of data from our recently completed trial with psilocybin to treat alcohol use disorder, building on what's already been published in that JAMA Psychiatry article. And so it'll be a fairly data-heavy presentation, and I'll try to finish in time so we'll have good 15 minutes or so for discussion and questions at the end. So there we go. Okay, so my disclosures. I do some a bit of consulting and on the 3 advisory boards that you see here, in addition to research funding. So just quickly background, most of the people who are listening probably are aware that there was quite a bit of research done in the 1950s and 1960s on the use of psychedelics. And the most studied indication really during that time by far was alcohol dependence, or alcoholism as it was called in those days. And there were thousands and thousands of people who were actually treated. The actual studies that were conducted were definitely had their limitations in terms of their methodology, sample size, outcome measures, and just methodology in a number of respects. But when a meta-analysis was done this was published in 2012, Krebs and Johansson looked at the 6 randomized controlled trials that had been published using LSD to treat alcohol use disorder. And these were fairly sort of motley assortment of studies, but they all used a single high dose LSD session versus some form of control treatment. And combined with anywhere from essentially no psychosocial treatment or therapy to really pretty extensive preparation and integration. And what the study showed was that among these a total of 325 participants who received LSD versus 211 receiving a control treatment, there was a quite consistent and fairly robust effect favoring LSD over control. And the overall odds ratio at the first follow-up was just about 2. So a little bit less than that, but still close to twice as many LSD treated participants were in essentially in remission, either abstinent or drinking without any consequences or heavy drinking. So that was, and these effects were still significant out to at least 6 months in the studies that included a 6-month follow-up time point. So within the limitations of the studies themselves and the meta-analytic methodology of combining these, really rather different studies, it's still pretty encouraging sign to see that when you combine these studies, you get a pretty consistent and robust treatment effect. So as Dr. Yehuda mentioned, I started this pilot study with psilocybin to treat alcohol use disorder back in, I think the first participants in were in 2012. And this was when I was at the University of New Mexico. And this was just a simple single group open label study with 10 participants aiming to try out the treatment, assess the tolerability and feasibility, and to look at pre-post changes in drinking, and also to evaluate various psychological effects that we thought might be relevant to the any treatment effects that we see. And the model that we used in this study was pretty similar to the one that was used in the randomized trial that I'll present shortly, so I won't go into that too much, but there were 2 sessions with relatively high dose psilocybin that were at weeks 4 and 8 of the treatment, and 4 weeks of therapy before the first medication session, 4 more sessions in between session 1 and session 2, and then 4 more after the second session. So the entire treatment was a total of 12 weeks with the medication sessions at week 4 and week 8. And this slide tells a story pretty clearly in terms of the drinking outcomes. This is % heavy drinking days. At baseline, when people entered the study, they were having about 35% of their days were heavy drinking days. And there was a drop, which was statistically significant during this first 4 weeks when they were receiving therapy but hadn't received psilocybin yet. However, in the following months after that first psilocybin session, the heavy drinking days dropped quite dramatically, and then those gains were more or less maintained over the entire 8 months after that first session. So this was, of course, open label and very, very limited in terms of what we could say about the effects of the psilocybin, but it was encouraging to see that that there was improvement on top of the improvement during the sort of run-in psychotherapy phase. So this seemed like solid justification to proceed with controlled trials. So this the study that we recently published ended up having 95 randomized participants, and 93 of them received medication and were included in the outcome analyses. These were, most of the participants were recruited at NYU, but the first 13 of them were at University of New Mexico. So it was technically a 2-site study. And these were all adults with DSM-4 alcohol dependence. We didn't have the DSM-5 version of the SCID when we started this study, or at least when we wrote the protocol. So that's why it's DSM-4. But this maps pretty closely onto what we'd now call moderate to severe alcohol use disorder. So these were people with, clinically very significant drinking problems. And the medications were psilocybin versus diphenhydramine. And if we have time later, we can talk about why we chose that as a control condition. And again, there were 2 dosing sessions. at week 4 and week 8, and follow up out to week 36 in the double-blind phase. And then once participants who made it through to the end of the double-blind were offered an optional open-label psilocybin session at week 38 after the double-blind. And so I won't be presenting results from the open label, but we the majority of the participants did have a third session after they completed the double-blind. And the treatment, just a little bit about the content of it. Each participant had a team of 2 therapists who provided the therapy together, present, both of them for most of the sessions. And you can think about it in terms of the alcohol-focused component of the therapy and the component of the therapy that is really geared towards providing a safe container for the psychedelic experience. So the alcohol-focused treatment was a combination of motivational enhancement therapy and some manualized CBT focused on skills training, identifying high-risk situations and doing some functional analysis and figuring out what kind of behavioral strategies to come up with to deal with that. So it was fairly bread and butter, evidence-based treatments for psychosocial treatments for alcohol use disorder that are known to be effective. And then the other component was, we call it PSI, preparation, support, and integration. And this is, fairly standard material that's similar to what's outlined in the Matt Johnson's paper on safe administration of psychedelics, and it involves, psychoeducation, rapport building. We do a bit of a life review and work with people on how they can negotiate the intense experience, and then afterwards, fairly non-directed, patient-centered exploration of the experience and sort of support in making meaning out of those experiences and applying them to the problem at hand, which is to try to change their drinking. So that's fairly generic, what some people have called it sort of the set and setting approach. It's basically to provide a safe container for the experience. In terms of the medication, first session used a dose of psilocybin that was 25 milligrams per 70 kilograms, and the diphenhydramine group got 50 milligrams. And then in the second session, the dose was titrated based on the intensity of the experience in the first session. So the people who had a relatively mild response to the psilocybin, based on a cutoff score on one of the scales of subjective experience, were offered a dose of 40 milligrams per 70 kilograms, which is a pretty big dose. And those who already had a pretty robust experience on the 25 milligrams per 70 went just up to 30. So the intention was to, try to bring the people who were relatively insensitive to increase the dose enough for them to have a strong experience in the second session. And then I'll show you the outcome measures as we go through them later, so we don't need to talk much about that, but just that we continued double-blind follow-up all the way out to week 36 and used the standard timeline follow-back methodology to assess their daily drinking throughout that period. And the a priori primary outcome measure was % heavy drinking days during the entire period from the first psilocybin session out to week 36. For those who don't do alcohol research, the definition of a heavy drinking day is 5 or more standard drinks in a day for a man, or 4 or more standard drinks in a day for a woman. And a standard drink is 14 grams of alcohol. It's the equivalent of a 12-ounce 5% beer, 5-ounce glass of 12% wine, or an ounce and a half, a shot of 80 proof hard liquor. So yeah, just briefly in terms of flow of patients through the study, we had very good rates of treatment exposure and retention in this study. 93 out of the 95 randomized participants received at least one dose of steady medication. There were some who did not receive the second session in both groups, but almost all of the patients completed their 12 weeks of therapy, and all but a handful, 5 of them literally completed follow-up out to the end of the double blind. So overall, out of all of the months of follow-up for the participants, we had over 95% complete follow-up data for our timeline follow-back. Briefly on the, just to characterize the sample, and the main thing to notice here is this was a relatively affluent, relatively white sample. We had a pretty good gender balance, and but not a terribly diverse sample. And in terms of percent drinking days, yeah, they were drinking 3 out of 4 days. More than half of their days they were drinking heavily, and the overall drinks per day was 4.8, and drinking days, the drinks per drinking day was about 9. So this is probably a little lower in drinking intensity than the average clinical trial for alcohol use disorder for pharmacotherapy anyway, but still pretty substantial drinking going on. And you know, as I mentioned, they all met DSM-4 alcohol dependence criteria. So this is maybe not the most exciting thing, but you know, one of the known side effects of psilocybin is that it does have some sympathomimetic effects. And so we see a pretty consistent increase in both blood pressure and heart rate during the session, which returns to baseline at the end by 6 hours, which is the end of the, you know, sort of the formal monitoring during the session. And the subjective effects are generally completely gone by then as well, or almost. So none of these participants required any kind of intervention or had any symptoms related to their blood pressure, but they were screened. People with out of control hypertension were screened out, although we had a number of people who were on antihypertensive medications and with good control, and they did just fine. To give you a little bit of a sense of the subjective effects, these are the scores on the 5-dimensional altered states of consciousness questionnaire on the first dosing day. The scores on the second day were very similar. So I'm just going to show you this one. But, and this is out of 100% of, you know, would be the maximum possible score on these. So they had pretty high scores on, this is the oceanic boundlessness scale, which is similar to the overlaps with the content of the mystical experience questionnaires. This has to do with experiences of unity and transcendence, and that whole dimension of the experience, which has been, you know, emphasized a lot in terms of the treatment models. Although we don't really know that that's what's driving any of this. The second one here is dread of ego dissolution, which is the sort of bad trip kind of symptoms of anxiety, fear of loss of control or disintegration, paranoia. So that was not so high, but significantly greater than the control group. And then the third one is the visionary restructuralization, which is essentially the visual alterations. The fourth one is auditory alteration. And the last one is vigilance reduction. And so you can see the diphenhydramine group over in blue did report a significant amount of vigilance reduction. So, you know, this was a psychoactive dose of diphenhydramine, but it was not a psychedelic dose, certainly. Similar on the mystical experience questionnaire. So all four of the dimensions of the 30-item version of the scale were markedly elevated to the extent we'd expect, and not so much in the control group. And I wanted to show this because I'm not aware of another study that used this approach to titrate the dose. And so it did seem to be effective in bringing the relatively insensitive participants up to closer to the scores that the other participants had. In green here, this is the group that ended up getting 40 milligrams per 70 kilograms in the second session. And they did so because their scores in the first session were low. So you can see they were significantly lower than the rest of the patients here in the first session. And in the second session, their scores went up a fair amount. So they're pretty close. The 30 milligram group they actually went from 25 to 30 milligrams per 70 kilograms. And, you know, it looks like their score goes down a little bit. And I think this is an artifact of the anchors of the mystical experience questionnaire saying, you know, for the 5, it's like the strongest experience of my life. So if you had the same experience 2 times in a row, the score would probably be lower the second time. So I need to look at this actually for some of the other scales that don't have that issue and see. I would imagine that the experiences were slightly more intense actually at slightly higher dose, but we'll see. But so that was 15 people, and in that group, these very high doses of psilocybin were very well tolerated, but that's because they were selected on the basis of their relative insensitivity. But we had, because this was weight-based, the highest dose was somewhere over 65 milligrams. I mean, so, you know, some of these people got up pretty high. In future studies, we're probably not going to be using the weight-based dosing. So I think, you know, there probably is a small price to pay for that, but it's probably worth it in terms of overall simplicity of design. And in the future, if the drug's ever approved, we would have the option potentially of titrating the dose. Blinding integrity. So this is the bad news and probably the biggest limitation of this study, which is not certainly not a unique problem to this study, but kind of comes with the territory, but it is you know, something we have to grapple with. So we asked the participants and the therapists to guess which drug they received, and the participants guessed correctly, you know, over 90% of the time, almost 95% of the time, and so did the therapists. And the confidence, we also asked them, how sure are you of that? So they weren't necessarily 100% confident, but most of them were pretty confident as well that they were guessing the right answer, and you know, they were right in most of the cases. So the diphenhydramine, in spite of being mildly psychoactive, really did not have introduce a whole lot of uncertainty in terms of people's knowing what they got. Safety-wise, there's not a whole lot to say here. Well, there's a few things. So this is just, you know, there were lots of AEs reported, and this table just shows the ones that were at least twice as common in one group as the other. And I highlighted the side where they were more common. So you can see the ones in bold in the psilocybin column here are the ones that were more common in psilocybin. And the ones that I think are, you know, likely to represent real side effects are the headache, which was, you know, much more common. Almost half of the psilocybin treated people had mild, usually mild, occasionally moderate headaches. following the session. And nausea was, not statistically significantly higher, but was fairly common in the psilocybin group. And anxiety, this was like, reported actual, clinically significant anxiety was, marginally more common in the psilocybin group. There were 2 participants in the double blind who received diazepam during one of the or more of their sessions because of severe anxiety. And it worked quite well in terms of diminishing the anxiety and allowing them to continue in the session. And so I think it's good to know, though, that there really are cases in which it's appropriate and probably clinically necessary to give people pharmacotherapy for the anxiety. In the open label study, we also had one participant who received 5 milligrams of olanzapine for paranoia that they were experiencing, which did not respond to the benzodiazepine that they were given first. So this transient paranoia is not all that uncommon. Clinically significant paranoia that require treatment, less common, but it does occur. So I think this is all just to underscore, this really does need to be done in a clinical setting, and medical intervention needs to be available, because every so often somebody's going to really have a hard time, and it could go badly if we're not able to treat them. Okay, so getting to the main event here, the drinking outcomes. This is the primary outcome, which is reported in the paper, was percent heavy drinking days in this repeated measures multivariate model that we used. And so you can see, as in the pilot study, there's a significant reduction in drinking during that first month between screening and the first medication session when people haven't been treated yet with medication. So both groups they decrease their heavy drinking days by more than 50%. And then in the subsequent months after that first medication session, there is a further drop in drinking among the psilocybin treated individuals, and the control group pretty much stays flatline from that point. Although they do maintain the gains that they made during the first month with the psychotherapy. So overall, this was a statistically significant and solid medium-sized effect size with Hedges G of 0.52. And so this, it's encouraging to see the big effect, and also that it's maintenance essentially over time. There wasn't any time by treatment interaction here. So although it looks like the effect might be getting a little smaller toward the end, it wasn't clear that that was a meaningful loss of the separation over time. Drinks per day, this looks very similar. But it's another very useful measure. Is just total amount of alcohol consumed on average per day, and it looks basically the same, and the effect size is about the same. For percent drinking days, which is sort of the inverse of percent days abstinent, the effect was a bit smaller, and this maybe isn't that surprising, because actually less than half of the participants in this study had a goal of abstinence coming into the study. So we asked them about their treatment goals, and more than half of them had some kind of a controlled drinking goal. We looked at a number of dichotomous drinking outcomes, and so this table shows people's status both for the entire follow-up period, which we used in the for the primary outcomes, which is weeks 5 to 36, and then also for the final month of that period. And so all of these favor psilocybin, significantly so in most cases. And just to highlight a couple of these, in the final month here under abstinence, weeks 33 to 36, the psilocybin treated group, 48% of them were abstinent versus 24% in the control group. In terms of no heavy drinking days, in the for the entire follow-up period, it was 33% versus 11%. And in that final month, 62.5% of the psilocybin group had no heavy drinking days. And we also looked at these World Health Organization risk level changes. And there's pretty good consensus that these, the World Health Organization risk levels are based on drinks per day, essentially, with different thresholds for men and women. And there are, the categories are abstinence, which you may or may not want to treat as a separate category. Abstinence, low risk drinking, which is up to, depending on male versus female, 1 or 2 drinks per day. And then there's moderate risk, high risk, and very high risk. So a 2 risk level reduction in drinking, and probably even a 1 risk level reduction in drinking has measurable health benefits. And so in our next study, we're actually going to propose this, the 2-level decrease as our primary outcome to the FDA. And they haven't accepted that before, but they said that they are open to this. And so we're arguing that that will be the primary outcome. And they've accepted the design of the study, so that I guess they have accepted it, although we're not to the point of asking for an indication. But again, about a 20% difference in terms of World Health risk level decrease between the 2 groups. So a couple of subgroup analyses here that I thought were interesting. As you saw in the earlier slides, a fair number of the patients cut down their drinking quite dramatically before they even received study medication. And so I wanted to know, is there is the treatment effect as the same for people who've already cut down their drinking based on the psychotherapy, or and those versus those who are still drinking more heavily? And so I divided them into the sample into people who at week 4, it's called baseline here, but this would be that week of therapy, that month of therapy prior to receiving the study medication. Those who were drinking at a low risk level or abstinent versus those who were still drinking at least at that moderate risk level. And then we looked at how many of those people had no heavy drinking days. So the people who were still drinking at least at moderate risk, that these are the groups that we're calling high. So that means high risk level, at least moderate to high to very high. So these people, almost all of them were having heavy drinking days. So we're looking here, the graph shows those who had no heavy drinking days. And each month, what percentage of the group had no heavy drinking days? So 100% would be perfect, no heavy drinking days in anybody. So those groups that were still drinking too much showed a really quite robust separation over time. And the psilocybin treated individuals, more and more of them, up to about 50%, by the end of the study were no longer drinking heavily at all, whereas the control group, the vast majority of them continued to have at least some heavy drinking days. If we looked, the dotted lines now, the people who had already cut down their drinking to low risk prior to receiving study medication, both groups improved a little bit more, but there's not nearly the kind of separation between the groups that we saw in those who were still drinking heavily. So it looks like there's a bit of a ceiling effect here, in that the people who responded to psychotherapy really responded pretty well to psychotherapy, and the medication didn't add a lot to that, at least in this study. Abstinence was a little bit different. There does seem to be a difference between the psilocybin and the control group, even among the people who had already cut down their drinking in the first month. It looks like maybe a bit more robust in the people who were still drinking heavily, but it's less of an interaction there for abstinence than for the heavy drinking days. Looked also at gender. Again, these are secondary. We're not powered to, really test any hypotheses here, but I think descriptively it's interesting to look at. So there's really no suggestion here of a gender by treatment interaction. Maybe the men are doing a little bit now, probably not even here. They're really pretty much the same, the men and the women in the two groups, and you see the psilocybin groups in red are doing better in both genders. And then in terms of total abstinence, again, the psilocybin groups are clearly doing better. It sort of looks like the men may be doing little bit higher percent abstinence overall, but nothing very impressive there in terms of gender effects. So I'll take you through a number of these secondary outcomes here quickly, because these graphs will all look pretty much the same, but this is the short inventory of problems related to drinking. And psilocybin again in red, both groups improved, but the psilocybin group improved substantially more, accounting for baseline in all of these analyses. Craving, significantly greater reductions in the psilocybin treated group, which persisted over time. This is the Penn Alcohol Craving Scale, total score. Temptation to drink on this is the alcohol abstinence self-efficacy scale. And the first half of that is temptation. How tempted would you be to drink in various situations? So it's sort of a hypothetical craving scale. And in this case, the separation didn't really occur until after the second medication session, but then occurred and persisted robustly over time. And then the confidence scale is the actual self-efficacy. It's how confident are you that you could resist the urge to drink in these various situations. And so the psilocybin group increases steadily in confidence throughout the trial, and the control group stays pretty flat. And then self-compassion. This is a scale that we added right at the beginning of the study because of the interest of one of our study coordinators at the time who went on to graduate school, Gabby Agan-Leibus, who's now is a PhD psychologist, and did her dissertation on this. So self-compassion is a measure of pretty much what it sounds like, being forgiving, gentle, compassionate towards oneself, and not having a lot of negative, judgmental, self-critical feelings dominating your sense of yourself. And so we see a really very dramatic increase in self-compassion in the psilocybin treated group, starting 1 week after the initial treatment, and then increasing over time. So this is, as far as I know, the first study that's actually used this scale with psilocybin. But it, the effect's quite large, and it certainly is consistent with, what a lot of our participants report about their experience of themselves, and how the experiences with the medication changed that. Personality, we also saw some of the same changes that have been reported in other trials: decreased neuroticism, increased openness, and also increased extroversion and increased conscientiousness in the psilocybin treated individuals. And it's interesting to look at what the actual facets, subdimensions are that were significantly affected. So with the neuroticism, there was decrease in depression, impulsiveness, and emotional vulnerability in the psilocybin treated individuals. Extroversion, this was driven primarily by increase in positive emotions. And in openness, it was openness to fantasy and openness to feelings. So this kind of goes along with the feelings part, I think, and it goes along with the self-compassion. And then finally, conscientiousness, increased deliberation, which together with the decreased impulsiveness suggests, improvement in executive control or response into mission. And overall, you could also map some of these changes onto increased mindfulness. We didn't have a mindfulness scale in this study, so I can't speak to mindfulness directly, but both the openness and combined with less impulsiveness and more deliberation sort of is consistent with increased mindfulness. So so those are all, these changes in any case are all things that seem relevant to being able to stop drinking. So we did look at the subjective experience in relation to changes in drinking. I need to do a lot more work here. I haven't looked at all of the scales or, in every possible way, but so far, I really haven't found any strong or statistically significant relationships between the magnitude of the subjective effects and the degree of improvement, either within the psilocybin group or the control group or across the whole sample. And whether this is due, it would take a lot more than this to convince me that the subjective experience isn't important, but it may be that most of these people, all these people in the psilocybin group received a high dose of psilocybin or 2 high doses of psilocybin and had most of them what they would have characterized as intense, strong, meaningful experiences. So it may be that it's not so much a quantitative thing, that there's even though these scores are not particularly high, they were sufficiently powerful and meaningful to drive subsequent change. But we'll need to do a lot more work on this. So to conclude, we had no significant safety issues in the good sized trial here, which is good to know. The drinking outcomes consistently favored psilocybin over the control. And these effects are larger than those of any currently available treatments and persisted at least 6 months after the end of treatment. So that's something that psilocybin has going for it over, really any treatment that we've looked at so far. And there were also persisting changes in a number of these psychological domains that we looked at, including craving, self-efficacy, self-compassion, and personality. So Those are all plausible, mediators of a therapeutic effect, but we haven't, I haven't done formal mediation analysis, and I don't think in a sample like this we can really necessarily demonstrate causality, but there's at least that association. So there's a lot more analyses that need to be done in this study. We have the open label data as well to look at. The next study that we're planning to launch next spring is a multi-site, larger study with 226 participants. It's sponsored by the BMOR, which is a not-for-profit corporation that's been set up to support development of psilocybin and other psychedelics for addictive treatments of addictive disorders. And it will be conducted, it's listed as a phase 2B study, but we're conducting it to the standard of a registration trial and hoping that it'll be accepted for that. And I do have a grant proposal pending for a NIDA-funded add-on to use computational measures and EMA to look at how people are thinking and how they are feeling and craving and doing on a day-to-day basis. So lots more work to be done, both in this for alcohol and moving into other addictions and co-occurring conditions. And so I think it's this is a good step forward, and excited to see what we're able to do over the coming years with this. So that's it.
Wonderful. Thank you so much, Dr. Bogenschutz. That was really excellent. With that, I'd like to move forward to the Q&A. If any attendees would like to submit a question, please do so in the chat. And I'll start it off. One of our attendees has asked, does the spike in heavy drinking days in weeks 21 to 25 in both control and psilocybin treated groups correspond to a typical recovery period curve for someone with AUD?
Let's see, spike in, I guess I'm not sure what we're referring to here. I guess I need a little clarification about what the question is. Is that there appears to be some increase in drinking during those couple of months towards the end of the study?
Correct. And I think comparing that to what a typical recovery period curve is for someone with AUD outside of a study like this.
Yeah, I guess I just wouldn't make too much of the month-to-month variation. I mean, it looks fairly significant on the percent heavy drinking day, the percent drinking days. Really not so much on the heavy drinking days or the drinks per day. So yeah, I'm not sure about that. And given that it sort of starts to come down again in the last couple of months, I think that's, I can't really think of why you'd have a blip and then they'd start to do better again, unless it was just that they were approaching the end of the trial, or so I would interpret that as, if it were replicated in future studies, I think we'd have to think about that. I think the simplest explanation is it's kind of a blip, but we'll see.
Understood. And for our next question, I think we have Kathleen.
Okay, yes, thanks for your very interesting and encouraging presentation, Dr. Bogenschutz. In some of your previous work, you discuss alcoholism typologies. Based on your experience, are different psychedelic drugs and/or psychedelic-based therapies or non-psychedelic therapies better suited for different alcoholism typologies?
That's a great question. One of the big questions, and this is really, for all treatments, we haven't done very well in identifying or being able to predict who's likely to benefit from particular treatments. And so this is, when we talk about personalized medicine or precision medicine or whatever we want to call it, there's obviously lots and lots of interest in this because most of our medications, hopefully psilocybin will have a relatively large effect size, but even if it does, it's going to work for some people and not for other people. Nothing's going to work for everybody. So identifying those people who are likely to respond is very important. It's not that easy to do. You generally need really pretty large samples to do that. Our group's been doing a lot of work recently using machine learning algorithms to identify likely responders, and you need at least a couple hundred participants to do these kind of analyses, and even then they need to be replicated. So so the short answer is I don't know, because we don't have any data on that. I showed the slide suggesting that the people who did not respond to psychotherapy had a larger treatment effect, and so perhaps that means that people with more severe addiction would have a larger treatment effect. But I think, I would certainly not want to hang my hat on that at this point at all. The work in LSD, by the way, in the 50s and 60s was generally in very severe patients who were inpatients, treated for inpatient for a month or more, and then they received the LSD, and they had these, in some cases, persisting benefit from that. So more work is needed. I think, based on this, we'll be trying to focus on a slightly more severe population in our upcoming studies. And the next study will be large enough to be able to at least start to explore, to do some of those likely responder analyses in a sample of over 200. So
Great. Thank you so much.
Wonderful. I think Lauren has a related question.
Yeah. Yes. Thank you. And yeah, thanks for the great talk. And thinking about non-responders, I was also wondering about the participants who dropped out of the psilocybin arm, especially. Do you know anything about something about their experience with the psilocybin or other features of their illness or demographics? Is there any sort of pattern there?
The ones who dropped out with the diphenhydramine?
Oh, with psilocybin.
Oh,
I
with
guess
psilocybin?
arms, but,
Well,
yeah.
we really didn't. We didn't have a lot of dropouts. So there were people who, there were a couple of people who did drop out, and then there were even those, all but one or two of them completed the psychotherapy part of it. So but just for example, there was one person who had one session, described it as the single most painful experience of his life, and couldn't really explain that much about what it was, but it involved sort of dry heaving and being horribly, he had this purging kind of experience, and it was just a struggle, and there was no sort of redemption, sort of positive aspect of the experience during the experience, but it's surviving that and being through it as a sort of ordeal seemed to be very powerful for him. And so this is somebody who refused the second session, but was entirely abstinent for the duration of the study. Finished the study, contacted us later. He'd gone back to school, become a social worker, and was working with addicted people to try to get them into treatment. So it completely turned his life around. But you've asked him about the experience. He said that was horrible. That was like the worst thing ever.
Wow, fascinating. Thank you.
And Dr. Yehuda?
Yeah, thank you so much for that. That was a really great talk. I really enjoyed it. I wanted to really ask you to comment on two things quickly, if you care to. First is just in terms of the psychotherapy support that people in the study received, and how important you think the psychotherapeutic support was to the psilocybin treatment. And related to that, you're one of only a handful of people that have been able to work with both psilocybin and MDMA assisted psychotherapy. And I just wanted to maybe get your perspective on how similar or different. We're about to start a psilocybin study, so we'll join you in that group soon, hopefully. But just to get a sense from you of just how different it is, because it feels pretty different working with MDMA, which is a very heavily focused psychotherapeutic container, versus this, which seems less so, but that's what the question is.
Yeah. So I do believe, and we haven't done these sort of upside down studies where we're varying the therapy and keeping the drug the same, which we ought to at some point soon. But I don't know that the specific content of the therapy is all that important, but I think sort of non-specific aspects are very important in terms of establishing a safe and supportive environment, and being able to provide some confidence and some kind of framework for thinking about recovery, regardless of what the framework might be. I think the intention of the patient is critical, at least in addiction treatment, and I think in PTSD as well. I'm not sure it works quite the same for if you're treating major depression, but people, these drugs increase the capacity for change, but they don't really push a person necessarily in a particular direction. I mean, especially psilocybin, I think. So absent a desire to change drinking, I don't believe that if you walked onto the detox unit and you slipped some psilocybin into people's coffee, that they would do better in terms of their drinking. I just don't think it works that way. So I think it's an interaction between the drug and the therapeutic set of the individual and a therapeutic setting that allows them to work on the changes that they're making and keeps them focused on that and helps them to be able to use the experience that they've had in the service of the change they want to make. So I think that's probably all true for psilocybin and MDMA. But the therapeutic process is different, especially within the actual dosing session. There's very little therapy that goes on in the psilocybin sessions for the most part. It's support and people's intentions or people's attention rather is we encourage them to focus inward and not get enchanted with the wallpaper or with talking to their therapist about the cool things that are happening, because that's not what's going to be useful. Whereas with the MDMA, there is a lot more, so you know what that model looks like, and there's a lot more active therapy and interpersonal interaction that is part of the process. So I think it's important. I think it's it's in the addiction work. It's mostly fairly non-specific. I don't think there's a particular kind of therapy that needs to be done. And in the common denominator with the PTSD treatment with MDMA too, I think is that again, it's not about with PTSD. It's not about exposure particularly. It's more about openness and acceptance of whatever comes up and being able to move through that and to become comfortable and be able to feel safe with what's actually going on. So it's that's somewhat similar to what's happening with the psilocybin, I guess. But yeah, the therapeutic process though is very different. Obviously, the experiences are very different. Some of our psilocybin patients, you know, would tell you that the experience, you know, it was not, their experiences were not about oneness and ego death. They were about forgiveness and love, you know, and so it's psilocybin can produce experiences that are maybe more like what we think MDMA experiences are like, but yeah, there's overlap, but there's definitely differences, and so.
Thank you so much.
Wonderful. Thank you again, Dr. Bogenschutz, for an excellent
Okay, my
lecture.
pleasure. Yeah, and yeah, people feel free to reach out to me if you have questions or want to follow up on anything.
Thank you as well to our attendees for joining. Apologies if we couldn't get to your question. There will be a recording uploaded later to YouTube, and please keep an eye out for future emails about their series of lectures in the future. Thank you again, everyone.
Okay, bye-bye.
Take care.